Hey everybody, it's Rishi Agarwal, and in this video I'm going to be taking a look at some clips from the TV show Chicago Med to see how accurate their radiology is. Alright, let's start.
Trying to figure out where I went wrong. Guy showed up this morning, I ran these, discharged him, and 2 hours later he's wheeled in with a massive MI. How did I miss it? Where was the lesion? Right coronary.
What?
I know what I'm looking for, and I don't see any abnormalities.
I got the guy back, but it's not good. It's not good.
Okay, so what's wrong with that? Well, he's pointed to the chest x-ray when the Asian guy asked him where the lesion was, and he said right coronary. And obviously on a chest x-ray, you can't diagnose a myocardial infarction. So that might be where he went wrong. So it's not uncommon, it's pretty common actually for in the workup of an MI to get a chest x-ray, because sometimes you can see things on a chest x-ray that can cause chest pain that might mimic a myocardial infarction or a heart attack. Like if a patient, for example, had a pneumothorax, that might cause chest pain. But if a patient doesn't have any of those things and actually has an MI, you probably won't see anything on a chest x-ray. Or if they have a big enough MI, then maybe they have heart failure and it's causing pulmonary edema. That might be the only thing that you can see on a chest x-ray. So the fact that they put that in there when talking about an MI is really weird, because this show is supposed to be like really good when it comes to medical accuracy. All right, let's take a look at another clip.
3. All right. Can you tell me your name?
Russell?
Help me.
All right, we're going to, bud.
All right, airway's intact. Get me a set of vitals.
Got it.
Someone draw gas and get a chest x-ray. Do you know?
Since I was a kid. Russell, can you move your fingers and toes? Where did this happen?
At the store.
Claire?
Sats 90, heart rate's 124.
All right, everybody quiet. Russell, take it.
Okay, it looks like this guy has a gigantic, like, glass sculpture penetrating through his chest. So it's going to be really hard to get a chest x-ray. Let's see how they do it.
Russell, take a deep breath for me, huh? I don't hear much on the left side. We're going to need a chest x-ray. It's not optimal, but we're going to do it from here.
Am I going to die?
Hey, Russell, listen to me. No, you are not.
No, you were gonna be fine. Excuse me, you'll have to wait right here.
All right, I'm going to hold the plate from here. You just shoot as head on as possible, okay? Here we go, Russ. Listen to me. You're doing great, buddy. I just need you to keep as still as possible, please.
X-ray? Everyone clear?
Clear.
Okay, that's not going to show anything. I mean, you have this humongous glass sculpture, like right on top of this dude's chest. Like I get irritated sometimes when I get x-rays of a patient's chest and there's too many EKG leads overlying the chest. So here we've got this humongous glass sculpture. That's going to be a really, really bad chest x-ray. The other weird thing is that whenever the x-ray tech said everybody clear, everyone went like this. Like that's not, it's not like, you know, when you're shocking a patient, you know, defibrillating a patient when you have to resynchronize their heart. Okay, so like touching the patient isn't going to like somehow shock you. Okay, so it's kind of weird that they all went like this. Now, you are supposed to back away. You want to be at least like 6 feet away from the x-ray source, especially if you're a healthcare worker. Like over time, like one x-ray is not going to make a difference. But if you are near x-ray sources like all the time, you want to at least wear protective equipment like this guy's wearing. He's wearing lead, or back away from the patient. So all of those people, if they weren't wearing lead, should have been out of the room. But I'm very skeptical as to how this x-ray is going to look, because like he's got this humongous thing overlying his chest.
Big hemopneumothorax with some shift.
Okay, so that's a very good chest x-ray. for the amount of stuff that he has on his chest. Like, all I see really is this one kind of cone-shaped thing in his left upper chest. I don't see this whole thing at all. So that's really really weird. Now, he said big hemopneumothorax. There is some haziness in the left chest, and he's supine, so that means he probably has blood in the back of his chest, like in the pleural space, hemothorax. And because there's probably also air in there, he probably has a deep sulcus sign, which they're not showing here, but I would guess that he has a hemopneumothorax too. So I agree with that diagnosis. All right, let's see what else we got.
Incredible.
Wait till you get the headset on. It's like I'm moving around inside of his body.
All right, so tell me how this thing works.
It combines images from the CT angiogram and creates a three-dimensional model of the patient's anatomy. With the HTC Vive, you get virtual reality. It allows us to better tailor our operation. Are you having some concerns?
Oh, no, just curious. Oh, by the way, Dr. Rhodes, I met your father today.
Okay, that was a little weird. I mean, the way they said with the HTC Vive, like, it's clearly a sponsored little partnership that they had. The way that they were using VR here, it seemed kind of superfluous and like not necessary. Most of the time in radiology, when we're making a diagnosis, we're using just the regular old axial images. But I could see how 3D recons can be used to kind of get a better visualization of the patient's total like anatomy or pathology. The addition of VR, I'm not sure if it helps that much, but I could see how in the future maybe VR could be used to do things that are not possible today. For example, like with like robotic surgery. So you could have potentially a patient who is remote from the practitioner. So you could have a robot being controlled through a VR system by a practitioner who's miles away, for example. That might be one application. I think there's a lot of potential for VR to change medicine, but the way they're using it here is kind of superfluous, and it just seems like it was stuck in as an ad for HTC. So I'm not a big fan of what they did here. Let's take a look at another clip.
Ashley's problem is right there. Superior mesenteric artery. The fat pad that supports it has shrunk and is now constricting the duodenum. So food passing through her stomach gets stuck in this pressure point. You're right. It is physical. You still could have told me you were going to give her a placebo.
So that was legit. And actually they used the right image too. So this is a patient who has SMA syndrome, where you could see that the duodenum is being compressed between the abdominal aorta and the SMA. And you can see actually in this CT image that they chose that the proximal part of the duodenum is dilated right before the SMA. So that was spot on. Good.
All right, let's get a look at his chest. X-ray clear. Hemopneumothorax. Dr. Choi, get a chest tube in on the right. You got it.
Roll.
Okay, here we have another hemopneumothorax. So yeah, I think that the picture that they used for this,
All right, let's get a look at his
let's take another look.
X-ray clear.
Yeah, the picture that they used is pretty good. So you could see that there's haziness throughout the right hemithorax, and there's this very subtle lucency at the edge of the lungs. So this is a hemopneumothorax in a patient who's supine. Now, the one criticism I have here is that they still, the people in the room, not everybody was leaded up. So, you know, for healthcare practitioners who are exposed to x-rays frequently, either you should get out of the room or you should be leaded, like the person who is at the head of the table here.
First, we need to discuss the results of your chest x-ray. We discovered a mass approximately 2 centimeters in diameter in the left lobe of your lungs. Now, a finding like that in conjunction with coughing blood, I'm concerned. We need a CT scan and then a possible biopsy.
Don't bother.
We really should determine...
It's cancer.
Yeah, that was not bad. Let's take a look at that chest x-ray again.
2 centimeters
Yeah, so what they're showing here is enlargement of the left hilum, and you can see that there's a spiculated lesion in the left hilum here. And it looks pretty good. So in a patient with that history of hemoptysis, I'm not sure if they mentioned it, that if he was a smoker or not, but hemoptysis and something that looks like that in the lung, I certainly would be concerned about lung cancer also. Now, it doesn't always have to be lung cancer. Maybe you could have some infection that causes hemoptysis too. Or you can have a patient with pulmonary embolism that causes hemoptysis, although it usually wouldn't look like this. But with this history and with that chest x-ray, I would certainly be concerned about lung cancer also. So pretty good. Now, in general, I think that Chicago Med does a pretty good job of the images that they do choose to show, because they do look like their actual pathology. But I think that the way they explain them and the context that they put them in is sometimes not completely right. And it seems like although a lot of their medical stuff is pretty accurate, when it comes to like the radiology, there's still some that is to be desired there. So I'm going to be looking at some more episodes. This was season 1 of Chicago Med, and I'll see if they improve in future episodes. All right, so this was a lot of fun. If you have any shows with Radiologist and you want to get my reaction, let me know and I'll be happy to take a look. Thanks.